post the recording of the meeting on our website, so you can go back to it and enjoy it again, or you can share it out with others. We will also ask you to do an evaluation to give us feedback. Tell us how we can do better, what speakers you want to hear from, and express any interest you might have if you want to connect with our speakers. Please put your questions in the chat. We will have a Q&A session, but if you put your question in the chat, we will make sure that you get an answer. And so with that, I'm going to go ahead and introduce our speakers for today. I'm going to start with Dr. Singh, who has already given you a wave. Please give us another wave so people know who you are. Dr. Singh is a gastroenterologist, and she's an associate professor of medicine here at UCSF. She is the director of the UCSF GI Cancer Prevention Program, and also the director of quality and safety for the GI division here in our university. She's passionate about medical education and has served as the director of GI medicine clerkship. So that's where we train our residents and fellows, and has received awards for teaching excellence from the UCSF Haile T. DeBoss Academy of Medical Educators. Her research interests include medical education, as I just mentioned, and then improving the identification and genetic testing for patients with Lynch syndrome and other high-risk family histories. So we're going to be focusing today on family histories and genetic cancers because it's something we need to talk about, and then also have information and know what we need to do in order to keep ourselves safe. After you hear from Dr. Singh, you'll hear from Dr. Ewing, who is a professor of clinical surgery here at UCSF. Her focus is on breast cancer surgery, nipple-sparing mastectomy, and sentinel lymph node dissection, but her other interests include quality of care and the evaluation of barriers to medical and breast cancer care for minority women. She has been involved in several studies about quality of care for breast cancer survivors, and specifically, these usually involve post-surgery symptom management and customizing risk assessment and tailoring treatment to the individual patient's medical profile and preferences. She has a primary focus on how being a breast cancer survivor affects the quality of life in different racial and ethnic groups, and how that relationship is modified by social support, depression, and spirituality. She was one of the faculty surgeons who trained me back when I was doing clinical work. And I'm just really excited to have her here today to share with you about what we used to call our prevention clinic, but is now called Familial Cancers or the Cancer Genetics Clinic. So I'm going to turn it over to Dr. Singh, then we'll hear from Dr. Ewing, and then we'll have an open Q&A session. But if you've got a burning question, please put it in the chat. Thank you all for being here.
All right. Thank you, Dr. Rhoads. I am so excited to be here today. We hear all the time about colon cancer prevention, but not a lot get talks about, hereditary colon cancer. So I'm so happy to be talking to you all. Let me share my slides. Can you see my screen? Perfect. All right. Okay. All right. So in next 12 to 15 minutes, I will be talking to you about introduction to hereditary colorectal cancers, some basics of genetic testing, and criteria for referral for genetic testing. I have no disclosures. So let me start this talk with a story with a patient, Miss J. So Miss J is a 35-year-old woman with constipation for 12 months. She does have a family history in her mother with colorectal cancer at age 49. So she was advised to have colon cancer screening 10 years younger than her mother's diagnosis, and she was told to start at age 39. She's 35 years old currently. So for her constipation, she was advised to exercise more, increase fiber in her diet. Ultimately, she is seen by gastroenterology and we offered her a colonoscopy. And her colonoscopy shows a cecal mass and diagnosed with a colon cancer stage 4. So what went wrong here? So this woman was diagnosed with Lynch syndrome. She did have a red flag family history. She had a first-degree relative, that's her mom, who had young age colon cancer, that's less than 50. And this patient should have undergone genetic testing and started colonoscopies at much younger age, around 20 to 25. So this was a miss. So Lynch syndrome is named after Dr. Henry Lynch, and it's the most common hereditary colorectal cancer syndrome. And it's due to germline mutation in mismatch repair genes. These are the genes listed here. And it's important here in this column to see that risk of colon cancer can be as high as up to 60% for a given gene MLH1, which is pretty high risk for a given patient. And these patients need to start colon cancer screening with colonoscopies at as early as age 20 to 25. And they need colonoscopies every 1 to 2 years. So that particular patient, if she was diagnosed in a timely fashion, should have started colonoscopy early, would have gone colonoscopies at more frequent interval, and possibly that colon cancer would have been diagnosed at a much earlier stage or prevented. So let me ask you a question. How common do you think is Lynch syndrome in the general population? Just pause for a second to think, just in average population, how common it is. It's about 1 in 300, very common. And the sad news is more than 90% of these patients are undiagnosed. They are walking around carrying the mutation, and most of them are not tested and do not undergo appropriate surveillance until they have cancer. So now let me switch gears to a different case, Mr. Y. So this is a 20-year-old gentleman, and he has a common complaint of intermittent rectal bleeding. He has no family history of colorectal cancer and seen by his providers, and guess that likely you have hemorrhoids. Again, increase fiber in your diet, hydration. So this person undergoes colonoscopy and he has 100 to 150 polyps spread throughout his colon and undergoes genetic testing, diagnosed with a second colorectal cancer syndrome, FAP, which is familial adenomatous polyposis syndrome. This syndrome is due to germline mutation in APC gene, and risk of colon cancer in these patients can be as high as 100%. So pretty much they are guaranteed to have colon cancer in their lifetime, most in much earlier ages. And it is interesting to note here that 25% of these patients can be de novo mutation, meaning they have no family history of colon cancer or colon polyps, just like this patient who had absolutely no family history but found to have this mutation. This person underwent total proctocolectomy and his risk of colon cancer reduced from 100 to 0%. All right, so let's switch gears. What are sporadic versus hereditary colorectal cancers? So just a reminder again, most of the colorectal cancers are sporadic, meaning they happen by chance. Second part of this pie is familial cancer. So familial cancers are due to clustering. So you may have multiple family members with colorectal cancer, but there is no well-defined one gene for these patients. And it's considered due to polygenic risk or environmental and lifestyle factors that they all run together in a given family. And the focus of today's talk is the smallest part of the pie here, the blue section, which is hereditary cancer, where you may have multiple family members and you can find a defined mutation. So 10% of colorectal cancer patients have hereditary syndrome. Here you can see again in this section that if you take all colorectal cancer patients and they all undergo genetic testing, you may find different mutations in up to 10% of these patients, and that can affect their management for that particular patient and their family members as well. So family history matters. A patient once told me family secrets kill patients. So it's very important to know your family history and share with your providers and also share with other family members. So in this table, we can see that if somebody has no family history of colorectal cancer, that person's average lifetime risk of colon cancer is about 4%. But if you go to the second column, which is one first-degree relative, so that will be your mom, dad, brother, or sister. So if you have any one of those with the colon cancer, the risk goes up to 9%. And if we go to the fourth column, that you have one first-degree relative with colon cancer diagnosed at young age, less than 45, your risk of colon cancer is about 15%. So here you can see how many members you have with colon cancer and also large colon polyps. That also defines that risk. And in my practice, I see most patients are not aware of if somebody in their family has large colon polyps. When I ask this question, I often get a surprised look. So important to share that information with your providers and your family members. So quick patient story again here. So from this website that a patient shares, until my diagnosis, there were no less than 13 doctors who could have taken detailed family history from the members of my family and referred them for genetic testing. It never occurred prior to the time I was diagnosed with a cancer. So family history is critical in risk assessment for patients, and genetic testing has become more affordable and accessible. Despite that, family history has not made into common history taking and routine part of the care, unfortunately. So quick slide about hereditary colorectal cancer syndrome. So there are two main categories. One is polyposis syndrome, and they have FAP, we talked about the patient, MAP, and hematomatous polyposis syndrome. In the non-polyposis syndrome, the major one is Lynch syndrome, and there are some other ones as well. Okay, so quick slide about what is a hereditary cancer. So it's due to a germline mutation. A germline mutation is a mutation that you are born with. So that mutation would be present in every single cell of your body. And these mutations do not develop over time. Unlike germline mutation, a somatic mutation is a mutation that happens, for example, in this cartoon, in the breast tissue of this person. So all cancers happen due to some mutation. So if there is a somatic mutation in this tissue, that will cause cancer, and this person will not pass it on to their children. Unlike that, a germline mutation will be present in every single cell of this person, and they will pass it on to their children. So the main question, when to refer for genetic testing? So if you have 10 or more adenomatous polyp, or if 2 or more hematomatous polyp, these are different kinds of polyps seen on pathology, that should be a trigger for your physician to make a referral for genetic testing. There are some other criteria listed here, like if your tumor shows mismatch repair deficiency, family history of known genetic syndromes, or if you meet NCCN criteria for testing or PREM5 model. So what is a PREM5 model? this could be a take home for anybody here in the audience to go check out. So if you just search PREM5 in your search engine, that should take you to this link. And this is a link, very easy. Anyone can use that. You can enter your family history of cancers and when they were diagnosed. And it does a nice calculation, takes, I think, less than a minute. And in the bottom, it can give you a score for you to discuss that you are high risk and you should get genetic testing. There could be a Lynch syndrome or any other cancer syndromes. So the risk is higher and you meet criteria for testing. So one is to use a PREM model. What are the other ways you can know? There are well-defined NCCN criteria for Lynch syndrome testing. And I'm not going to read all of them here. This slide can be a reference, but some major ones are, if you have one first-degree relative with a colorectal cancer or endometrial cancer diagnosed age less than 50. So it simply means anyone with mom or dad or brother or sister, if they had a colon cancer and at the time of their diagnosis, they were less than 50, you meet criteria to have genetic testing. And the other criteria here explain what happens if they are second-degree relatives, meaning your grandparents, uncle, aunts, how many of them should be there for your physicians to refer for testing for certain mutations. So how is genetic testing done? It's very easy, can be done from home. Generally, you talk to a genetic counselor and they can mail you a kit to do at home. You simply just spit in a small tube. Genetic testing can also be done on a blood sample, but saliva can often be sufficient. Turnaround time is about 2 to 3 weeks, and most of the insurance plans cover genetic testing. And out-of-pocket costs, so even if your insurance does not pay for it, you can pay directly, and the out-of-pocket cost for a large gene panel for 100 or 150 genes can be as low as just $250. So can be affordable for certain patients. Many patients often worry about discrimination based on genetic information. So in 2008, President Bush passed a law known as GINA, that's Genetic Information Non-Discrimination Act, which prohibits any discrimination of health insurance based on genetic testing diagnosis. However, some caveats, it does not protect you against life insurance, disability, or long-term care insurance discrimination. So certain patients, if they have time, they may buy life insurance before they undergo genetic testing. All right, so timely genetic testing is critical. So if you have a cancer or a family history, your physicians doing timely genetic testing can actually affect what kind of surgery you undergo. And also what kind of chemotherapy they may use for you. And a very exciting thing is a vaccine trial for cancer prevention. A human trial is already underway. For many centers are enrolling patients for colon cancer prevention in Lynch patients with vaccination. So here is a slide with some resources for you for genetic counselors or genetic testing information, or even some patients to share some information. And take home for this talk that 10% of colorectal cancer can be hereditary. It's very important to know your family history of colon cancer and polyps and discuss genetic testing and earlier colonoscopy with your provider. And consider colonoscopy, not stool-based testing. For those with high risk of colorectal cancer, stool-based testing should be done for average risk patient, not for those with family history or genetic mutation. And in this short time frame, that's all I had today. And I would like to thank you all again for attending, and Dr. Rhoads for the opportunity. I'll be happy to stick around and answer any questions. Thank you.
Excellent. Thank you so much, Dr. Singh. I learned a bunch of stuff just now, so I'm sure that our participants are also getting some new information. I don't, Lori, do you see Dr. Ewing in the room yet? Not sure I see her here.
Yes, I do.
Dr. Ewing,
Yes.
oh, I see Ewing
Yes.
C. Okay, great. So Dr. Ewing, we've already done your introduction, so we're going to go ahead and turn it over to you. I think we're sharing your slides.
Okay. I just got done with my clinic, so I'm sorry I was a little late.
No problem. So glad to have you here, and we will have an opportunity for Q&A after. So glad you're here. And Dr. Singh, thanks for sticking around. If you have questions as we're moving along, please go ahead and throw those questions in the chat. Dr. Singh, if they are for you, go ahead and feel free to answer them openly to everyone. And we'll try to do some out loud so that everybody can hear the responses for folks who can't see the chat. All right, Dr. Ewing, we'll turn it over to you to talk to us about breast cancer and hereditary risk.
Well, thank you, Dr. Rhoads, very much for inviting me to participate in this forum. One of the things that I have over the many years have learned in our community that there are a lot of people walking around who are extreme risk for breast cancer, and they have no idea that they're at risk and that they should be in a special surveillance and screening program and what prevention tools we have. So I hope that this talk will be informative to identify who's at risk for breast cancer, how do you identify that risk, and what you can do about it. So my next slide. So my take-home points is, who is at risk for breast cancer? How do I know that I'm at risk for breast cancer? How does genetic testing work? And what are some of the tools for screening and prevention? So those are my 3 take-home points that I hope everyone will take in mind. Next slide. So just some breast cancer statistics that happens in our country. So 1 in 8 US women, about 12%, will eventually over their lifetime develop breast cancer. In 2022, it's almost 300,000 women are expected to be diagnosed with breast cancer. About 50,000 of those women will have an in situ cancer, which means it's a pre-cancer. It hasn't quite formed a cancer, but it has the ability to become a cancer. And of those nearly 300,000 cancers, about 2,600 will be men. And a man's lifetime risk of getting breast cancer is 1 in 830. So it's pretty uncommon to see a male breast cancer, but it does happen. I just recently actually saw a man with breast cancer and prostate cancer last week. And about 43,000 of those women will eventually succumb to their breast cancer. Next slide. So who is at risk? Next slide. It's our sisters, our friends. Next slide. Our mothers, our daughters, our grandmothers, our family. Next slide. And to identify risk for breast cancer is a puzzle. It's so multifactorial. It's not one single factor that makes you at risk for breast cancer. So you have to take all of the characteristics for risk for breast cancer in account. You know, your age when you had your first period, the age of menopause, whether or not you've had atypical cells diagnosed when you're in your breast from a breast biopsy. You know, your BMI, are you overweight? Because we know that extra estrogen is made in your peripheral body fat, whether or not you were exposed to radiation when you were a child. So we have to take all of these factors into account and identify who is at risk for breast cancer and who is not at extreme risk for breast cancer. Next slide. So some of the things that you can look out for yourself are a new breast lump, particularly if it persists for more than 1 month. If you notice a nipple discharge, particularly if it's in one breast and not the other. If your nipple is being pulled in, it's what we call nipple inversion. Or if you notice that your skin is puckering or dimpling. Or if you notice that there's a change in the size of your breast, that it results in asymmetry. One breast is much larger than the other. Next slide. So how is breast cancer risk defined? Is he defined by genetic risks and then non-genetic risks? And that would be a combination of genes and environment. For today's purposes, we will discuss the genetic risks. Next slide. So the questions are, if you have risk, how much is your risk? There are actually risk assessment models you can use to give you a definitive number of what your risk is. And if you have difficulty with those assessment tools, your primary care doctor or nurse practitioner can certainly help you. But there are multiple assessment tools that you can look at online. And I just want to show you a few examples in the next slide. So these are 4 or 5 models that you can use to assess your risk. And they use a number of demographic data points to give you a level of risk. And it could be your age, your body mass index, how much alcohol you take, your age when you had your first period, age of menarche, when you had your first child, age of menopause, whether or not you've had a previous biopsy of your breast that noted atypical cells, and again, your family history. And these various assessment models, we use different demographic data points because all people don't fit into one model. So again, you can go online and look up any of these models and do your own assessment risk. Next slide. So some of the other risk factors that we look for is family history. Again, age of menarche, menopause, age of first period when you had your first child. A previous diagnosis of breast cancer actually will put you at increased risk over the general population. And again, a previous history of atypical cells or an entity that's called lobular carcinoma in situ, which is essentially much like the atypical cells. Next slide. Other risk factors, we know early radiation exposure, particularly as a child or during your teenage years. For example, if you were diagnosed with Hodgkin's lymphoma and they received radiation to the upper chest, or back in the 40s and 50s, a number of physicians had radiation machines in their office, and they would radiate women for thymus disorders, for acne, also, if you could even believe it, to measure the size of their feet. So any early radiation exposure during childhood or as a young or as a teenager or a young adult may put you at increased risk for breast cancer. Taking hormonal estrogen replacement is another risk factor for breast cancer. Again, if you've had a previous biopsy that showed atypical cells, and alcohol may be a factor. And alcohol may not necessarily be the factor, but because there's so many calories associated with alcohol, it may impact on your body mass index or obesity. Next slide. So who should get tested for the BRCA1 and BRCA2 mutations that are associated with breast cancer? But actually, there are other mutations that are also associated with increased risk for breast cancer. Next slide. And what the mutations are looking for when they do genetic testings are actually breaks or deletion in your DNA that suppress a particular protein to dampen down the development of breast cancer. And if that gene is defective, you may not develop that protein and therefore put you at risk for getting breast cancer. Next slide. And again, this is just a cartoon illustration of a genetic break in the DNA. So you can see that one strand is damaged. And so it will have a very difficult time to making a protein that we call tumor suppressor protein for breast cancer. And so if you have a mutation in your DNA that manufactures that protein, you won't be able to make it, and therefore the risk for breast cancer. Next slide. So this is a slide that looks at breast cancer incidence by race and ethnicity. So you'll notice that non-Hispanic whites have the highest incidence, followed by non-Hispanic Blacks. But the mortality that you'll see in the next slide among African-American women who are younger than 40 are at a much higher rate compared to white women. And so that's another reason why we should be aware of our risk. And then this is just another slide that demonstrates that we also have the more aggressive forms of breast cancer. Again, when you look at the different ethnicities and races, when you look at the African American group, we have the higher incidence of having the more aggressive forms of breast cancer. Next slide. And then these are for the BRCA1 mutations by rate and ethnicity. The Ashkenazi Jewish population has the highest incidence of being BRCA mutation carrier. So any woman who is Ashkenazi Jewish ancestry that has a family member, and it could be mother, daughter, grandmother, should absolutely get tested for BRCA gene. And any Ashkenazi Jewish woman with a breast cancer diagnosis is at extreme risk for being a BRCA mutation carrier. Next slide. And these are some of the associated risks of cancers associated with the BRCA1. So someone who's a BRCA1 mutation carrier has an 85% chance that they will get breast cancer sometime in their life, and 30 to 54% chance that they'll develop ovarian cancer. So that's why it's really important that if you are at risk, particularly for being a BRCA1 mutation carrier, that you identify your risk, because you need special screening for ovarian cancer, which is actually much more difficult to diagnose than the breast cancer. And the incidence of male breast cancer probably is not that much different than the general population, but they're very high risk for getting prostate cancer. So again, if you think that you may be at risk of carrying the BRCA1 mutation, and you have brothers in your family, they should be screened right along with you. Next slide. So these are the lifetime risks associated with the BRCA2 mutation carriers. Again, for breast cancer, it's pretty high. There's a 56 to 85% chance over your lifetime that you will develop breast cancer. The ovarian cancer risk is not as high, but it's still pretty significant at 20 to 30%. And the incidence of male breast cancer does play a role in BRCA2 mutation carriers. And there's one other BRCA2 associated cancer that's not listed on this slide, is melanoma. So that's another cancer that if you are a BRCA2 mutation carrier, you should be screened for. Next slide. So who are the women that we should think may be a mutation carrier? How do I identify that I'm at risk and I should get genetic testing? So any woman diagnosed with breast cancer under the age, we've actually elevated it in the most recent data to 45 years of age. Or if you have multiple cancers in one breast, or if you present with breast cancer in both breasts and under the age of 60. Any woman under the age of 60 with what we call a triple negative breast cancer, so that's a breast cancer that's not sensitive to estrogen, is not sensitive to progesterone, your female hormones, and the human epithelial growth receptor is a growth regulator. And if that's negative, so if all three are negative, that puts you at a high risk of being a mutation carrier, and you should absolutely get genetic testing. Any woman of Jewish ancestry, particularly of Ashkenazi Jewish ancestry, that would be Eastern European, Hispanic or Mediterranean heritage, and Norwegians under the age of 60 should get genetic testing. A breast cancer diagnosis, and with 2 relatives diagnosed with breast cancer, or 1 relative diagnosed with ovarian cancer, and that includes second-degree relatives. So that could be an aunt and it could be a grandmother. And it's not only on the maternal side, it's on your father's side as well. And let me give you an example. I had a young woman who presented at my office with a breast cancer diagnosis. And so she was under the age of 35. So she presented with the criteria for genetic testing. So we tested her for the BRCA1 and BRCA2 genes and other mutations, and she came back BRCA1 positive. Now, her father was Chinese. Her mother was Irish American. So the question was, well, what side of the family did she inherit her BRCA mutation? And it turns out it was her father's side of the family that she inherited the BRCA1 mutation. And so we had to contact the family members in China that there was this mutation in their family that they should get tested for. So it's not, again, it's just not the mother's side of the family, it's the father's side of the family too. So both histories are important. Next slide. So any man diagnosed with breast cancer should get tested because there's a high incidence that there's a genetic mutation, because breast cancer in men are so rare that when you do see a breast cancer in a male, particularly if they also have prostate cancer, should absolutely get tested. And then special attentions to a few other mutations, for example, the TP53 mutations that we see in melanomas and colon cancers, and others to screen our family histories with Cowden's disease. They usually have these sort of papillary lesions on the inside of their lip, and their heads tend to be a little bit on the larger side. Or families with Leigh-Fermani syndromes, they usually have a family history of leukemia, brain cancers, sarcomas, and skin cancers. Next slide. So I know that you heard a little bit about genetic testing, but it's a pretty easy test to undergo. It can either be an oral swab or it could be a blood test that will screen you for genetic tests. And this is just an example of the test results that you would get back, identifying the mutation and what you're at risk for. Next slide. And again, these are some of the other mutations we look for. They're actually, today now we have about 150 genes that we look at that may be associated with breast cancer, but these are our most frequent genes that we screen for when we think someone may be at risk for genetic related risk for breast cancer. Next slide. And if you do find that you have a genetic mutation, you should seek genetic counseling and enroll in a risk prevention program. And clearly we have one here at UCSF that's completely dedicated to breast cancer risk. Next slide. And if you do have a mutation, you may want to consult with a breast surgeon because there's multiple preventative surgeries that we have to offer. Again, consult with a genetic counselor and consult with a gynecologist because of the ovarian cancer risk. And if you may be at risk for melanoma, we may also refer you to a dermatologist to screen you for melanoma. Next slide. And these are some of the surveillance tools we use for women who are at increased risk for breast cancer. You get a clinical breast examination every 6 months. You get an annual mammogram and bilateral breast MRI, alternating 6 months apart. So every 6 months, you're getting a breast image, either mammogram, then followed by MRI, and then mammogram, and then MRI. If indicated, you'll have a genetic counselor as part of your prevention team. You can be offered an anti-estrogen pill to decrease your risk under certain circumstances with tamoxifen or laroxifene. And then we can also discuss prophylactic surgery, either with a mastectomy, which we do now as a total skin sparing mastectomy, where we spare all of the skin of the breast, including the skin of the nipple. So when the breast is reconstructed, it looks like a native breast if you don't tell someone you've had a mastectomy, because we spare all the skin. It's very cosmetically pleasing to our young women. Or a bilateral salpingo oophorectomy, which is removal of the ovaries if you're at risk for getting ovarian cancer. Next slide. So tools for prevention, again, you need to know your risk. Are you at risk because of your family history? Are you at risk because you've been exposed to radiation early on in your lifetime? Do you have a previous history of atypia? Screening mammogram or MRI, and again, annual breast examination. And if you think that you're at risk for genetic mutation that puts you at risk for breast cancer, early genetic testing is the key. Next slide. Other tools for prevention: to maintain a healthy weight, because we know obesity does contribute to the risk of breast cancer, because the increased peripheral body fat has a higher estrogen level. Exercise regularly. And interesting, a mini dose aspirin that heart patients take daily could also have an impact on risk for breast cancer. And one of the things that I really stress is that, women, we take care of everyone except ourselves. So whatever you can do to reduce stress in your life, if that's just going for a walk, getting a pet, reading in a nice quiet place, whatever you need to do for quiet time, it's very important for risk reduction. Next slide. Eat fresh fruits and vegetables, particularly those foods that have antioxidants in it. For example, blueberries, peaches, any dark green leafy vegetable. If you've noticed, kale has become quite popular. When I was a kid, the only thing we used kale for was a decorative piece for under your cheeseburger. But now, because kale's so heavy in antioxidants, it's become a very popular food item. And if you are eating fruit, it has to be a fruit with a skin that you can eat because the antioxidants are in the skin. So apples, pears, peaches, grapes, anything with a skin. And if you're juicing, you have to include the skin as part of your juice. Next slide. Remember, October is Breast Cancer Awareness Month. And if you haven't had a mammogram, mark your calendar. Next slide. And take a friend. Thank you for this invitation. And I'll take any questions that you may have.
Thank you so much. Both speakers, really informative. There are a number of questions, I think already kind of happening in the chat. I know that Dr. Singh has started to respond to some of those. I want to invite you to raise your hand if you have a question. If you have a question in the chat, we are gonna cover it. I may ask you to unmute and ask the question yourself. But I wanted to just kick it off and ask both speakers: are there mutations that are specific to or more frequently observed in people of color, both men and women, since we've got two kinds of cancers? And then we'll get to some of the questions that have been asked in the chat, and folks want to raise your hand, please feel free.
So
Dr. Ewing?
So we actually have been doing research with a few countries in Eastern Africa, particularly Nigeria. The highest genetic mutation that we have seen so far in our population are BRCA1 mutation. And we think it goes back to Eastern Africa. I'm sorry, Western Africa.
I did not know that about BRCA1.
Mm-hmm. And so that's why why young African-American women, when they are diagnosed with breast cancer, more often than not, are triple negative, because that's also associated with the BRCA1 gene.
Oh. And Dr. Singh, what about for GI cancers and colorectal in particular?
Yeah, absolutely. You know, we are seeing more and more genetic testing being offered to different parts of this world. And we see these mutations being as common in those parts as well. So in general, we see pretty much similar distribution in resource-rich or resource-limited countries as well. And depending on, as Dr. Ewing already mentioned, that Ashkenazi Jewish patients, you know, they have very high risk of different mutations and certain cancers in both breast cancer ward and colorectal cancer ward as well. So that's a different category, to the point that it's part of genetic counseling history taking if patients have Ashkenazi Jewish ancestry. So that is one important one.
Great. So I thought I saw one hand up, and I know it is one of our faculty members. I'm going to just take the liberty, as Barbara Arnold Perkins, our CAB chair, would say, you get to work with these folks all the time. So we're going to give the community an opportunity to ask their questions first. And I know that some questions have been answered in the chat, but I think there are a couple that are worth saying out loud and kind of sharing with everyone. And that question, the first question I want to ask is, how much does diet obesity add to the risk, even if there is no mutation? And I know it was said during the talks, but I want this to be, you know, sort of overemphasized because it is diet and obesity are things that we have control over. So question about how that adds to the risk, even without a mutation for cancer.
Certainly, I answered a little bit in the chat already. And as was mentioned, even if you have a mutation, these risk factors, which are known to increase your risk of not just colon cancer, various cancers, risk is higher in patients who have higher BMI and suboptimal diet. So for example, a certain mutation patients, if they have higher BMI, let's say a Lynch syndrome with MLH1 mutation, that particular cohort of patients with higher BMI have higher risk of colorectal cancer compared to those with lower BMI. So irrespective of the mutation status, these modifiable risk factors are very important. And I always tell my patients, we can't choose our parents, but we can choose our diet and lifestyle. And it really matters. So great question you ask, Dr. Rhoads.
And then there's one that actually was sent to me. So it's attributed to me, but it's for Dr. Ewing. What is the recommended age for a woman who has a history of breast cancer in the immediate family to begin getting an annual mammogram?
So again, it depends on how many family members have been diagnosed. We usually think of an elevated risk at 2 members diagnosed. And but if they're extreme risk, particularly if they're diagnosed as being a BRCA mutation carrier, say they're in their early to mid 20s, we recommend that they start a breast MRI at age 25 and then add mammograms at age 30.
Great, thank you so much. And this is of course being recorded so people can come back to this. I did see a hand up, Miss Wynn. Do you still have your hand up?
Yes, I do. Thank you.
Uh-huh.
Thank you, first of all, for having this forum. And I want to say thank you to both of the doctors. I have a question because I live in Hunters Point, and I remember seeing when I was at UCSF, there was a board, and they had a high risk for cancers and asthma, specifically in the Hunters Point area. But what I wanted to know, because it seems about more genetic, I was diagnosed with metaaplastic breast cancer, and there is no history of cancer, or at least breast cancer, on either side of my family, from my mom or my dad. And for a while, I got tested. So genetically, there's nothing, but it's like that question still comes about. So, well, how did I get cancer and where did it come from?
So Ingrid, one of the things that we know that we don't have all the genes. And every year we're adding more and more genes. For example, when the BRCA1 and BRCA2 mutations were first identified in the mid-90s, those were the only 2 genes we were working with. Now it's well over 200. So we're recommending that anyone who may be at risk for being a genetic mutation carrier, and it sounds like if you had a metaplastic breast cancer that you may probably fall into that category, that you repeat testing every 5 to 7 years.
Okay, thank you.
And Ms. Wynn, I just want to let you know that we are, our Office of Community Engagement is involved in exploring these issues around Superfund site in Bayview Hunters Point. So there'll be some opportunities coming up for breast cancer survivors as well as other stakeholders. And I do believe that Anne-Marie Charlesworth might be on the call. Anne-Marie, would you mind connecting with Ms. Wynn so that she's aware of the Bayview Healers project that is about to kick off? I do see Isabel Duran's hand is up, but I also want to remind everybody, if you do have a question didn't get answered, please put it in the chat. We will be getting answers to your questions and sending them back to you in a written form. We need to have your email address, so I hope you registered with us. And please fill out our survey evaluating the forum today. It'll be in the chat for you. Isabel, go ahead.
Thanks, Dr. Rhoads. Thank you, Dr. Singh and Dr. Ewing, for your presentations. They're always important and obviously always timely. I think the frustration for many racial and ethnic minority CABs or community-based organizations is we know these things, we try to educate our communities around them, but part of the bigger problem increasingly to me is both access, cost of genetic testing, and then consultation, genetic consultation in a language of origin. So while we're identifying the problem, we're not resolving the issues in order to get to the problem quicker. That is treatment, diagnosis, and care. How do you see that we can actually break through these issues? We know that in California, there are some increasing opportunities through Medi-Cal, but there are a lot of other states that aren't, and we get calls and emails from people who don't live in California and need help. So how do we begin to really break through and break down these systems barriers so that we can get equity care for our communities, the particularly vulnerable and underserved? That's the big question. Either one, please go.
I'll just add my quick thoughts, and Dr. Ewing can add more from the breast cancer side. So excellent question you ask. And as of now, genetic testing is like an opportunistic model, meaning it's if you see a physician, they have to assess the history, then make their referral to counselor, then they have to do the testing. And it's going to be a very small group of patients who make, to that point. And the larger group, and as I mentioned, that more than 90% of Lynch patients, they do not know their diagnosis. So some population level testing is needed. And a good example is Nevada, I think they call it Nevada Health Project. What they did is anyone with a strong family history in Nevada can get genetic testing. You go online and answer a few questions. So anybody, you don't need to see a doctor, you do not need a referral, and just go online. I think the website still exists. You may explore that as a model example. And they do not test for low penetrant genes. So they are testing for example, Lynch, BRCA, and I think the third one was familial hypercholesterolemia, if I remember correctly. So these three most common important genes, which are very common in general population, and you can just get tested. So I feel like that kind of model needs to be expanded. Let's just directly go to the communities and we take away the barriers of multiple providers and levels that is hard to break through. And, so that's a good example, but yes, a lot needs to be done on that front. If others want to add, please go ahead.
Right, I have to agree with Dr. Singh. It's a very complicated problem, and sometimes I just want to pull my hair out.
Me too.
It would be nice, maybe as part of to push our political leaders to set up in some of the community health clinics. We screen for, other diseases, and why not screen for that as well? There's actually a genetic test that's available called Color. That's not as expensive as the formal genetic testing, but will certainly give you adequate amount of information that could be part of that screening process. But somehow we need to make that part of our health policy. And I'm not sure how to go about doing that. I mean, I've talked to politicians and thought leaders for years, and just seems like nothing changed. But we'll keep at it.
Kim, can I do a follow-up?
Actually, no, Isabel, I'm sorry, because we only have 2 minutes and we've got a lot more questions, but can you connect with, we can connect you with the speakers to do your follow-ups if possible?
Sure.
I wanted to there were two kind of, regular everyday person kind of questions in the chat. One was, what is the relationship between breastfeeding and breast cancer? Is there a risk reduction at all? And then the other question is about sports, and is there any relationship between contact sports and the contribution to breast cancer for men and or women? And I want to remind everybody, please fill out our evaluation so you can tell us what you would like to see in our next CAB2 chat and choose the kinds of speakers and the topics.
So as far as breastfeeding, we know that there is a risk reduction with breastfeeding, but you have to breastfeed for a minimum of 9 months. But the risk reduction is very small, maybe 1–2%. So it's not a huge impact on risk reduction. And as far as having children, The age for risk reduction is to have your first child before the age of 24, which does not, I know, maybe 100 years ago, but that is not the modern woman. But that risk reduction too is also extraordinarily small. And we know that trauma has no relationship to breast cancer. There's been multiple studies done dating back to the early 30s that have clearly demonstrated that trauma does not increase the risk for breast cancer.
Thank you. And I think if you can see the chat, please take a quick peek. Allison from the Wisdom Study has added some information about the Wisdom Study, which can help you understand your breast cancer risk if you decide to participate. And in fact, you can get an update on your risk on a yearly basis. That's part of what the study is going to give back to you. I do want to ask a question that Jill Longcrier had put in the chat, which even though it was during Dr. Ewing's talk, I think is for both. And it is, what is the relationship between the genes tested for genetic risk, like the ones that we already know? What's the relationship between that and the Oncotype, which is a company, right? The Oncotype DX scores, which I think are available also for GI cancers, if not mistaken. So is there a relationship between like what we test for risk and what you get on an Oncotype DX panel?
Well, the Oncotype is not related to your genetic risk for getting any type of cancer. So the Oncotype, there's also a test that's called a MammaPrint, would basically give you the same information. It's actually messenger RNA, but I'll say it's the DNA sequencing pattern if you have a cancer diagnosis. And it's unclear how aggressive your cancer is. The Oncotype DX or the MammaPrint, again, giving you the same information, will give you a level of risk that your cancer can become metastatic, and also how you will respond to chemotherapy. And so it's a tool that the oncologist will use for your treatment planning. So for example, if you get an Oncotype and it's an Oncotype of your tumor, not of you yourself. And if the Oncotype of the tumor comes back that is high risk, you may be recommended for chemotherapy. So it's a decision making tool for therapeutics, not for your associated risk of getting cancer.
Great. And Appy, Dr. Singh, do you have anything to add to that?
I agree.
Okay. So I want to just thank everybody. We're 2 minutes over. I really appreciate you all being here. The staff from our office is going to stay in the chat, in the Zoom. So if you want to put more questions in the chat, we will make sure to add those to the list. Dr. Singh and Dr. Ewing, thank you for being here. You will get a letter and follow-up with your evaluation results and with any additional questions that the audience may have had for you, but we weren't able to get to on the call today. Remember,
Kim, can I just add one other thing? Allison, thank you so much for bringing up the Wisdom trial. Is there any way that you can provide a link to the Wisdom trial for someone who may want to be evaluated for risk at free cost? As part of the trial.
And then I would love to connect Dr. Singh with, and maybe this is relevant with for breast cancer as well, but to do the saliva-based genetic testing where our community-based movement pays for things, because we do have the capacity. That's how we're doing our colorectal cancer screening. It's actually our group that is paying for it. It's not UCSF per se, but it is our, a mobilized community partners group that is doing that. So we might want to explore how to bring the saliva-based testing out into the community.
I would absolutely love to collaborate on those, and any high risk patients should not be walking around untested. So yes, let's talk.
Awesome. Love it. Okay, everybody. Again, please go ahead and hang out in here while you fill out your evaluation. The link is in the chat. I'm going to let our speakers dip out because they've probably got to get back to their busy clinical lives. Thank you all for being here. The next CAB2 Chat and Chew, please invite 2 people.